if there's anything that might be more challenging than the cost of one drug, it's the cost of two drugs. So what did you think of a trial that was looking at the combination of pembrolizumab or Keytruda with Yervoy ipilimumab? It was presented by Patnaik and colleagues, and really not a large study, but Jean-Charles, I'll just ask what you thought of this, and if you think this is a direction where things are likely to go for efficacy and even feasibility.
Well, I think obviously unleashing the immune system to its greater extent is something that is being currently pursued because we are facing a fatal disease, a lethal disease, correct? And when you are told you have metastatic lung cancer, you realize that you may have only, as many Christmas, and you are ready to take a lot of tox if this is going to increase the number of Christmas. But once we see what is it on the table, I really think how much tox we get is going to become an important issue. And I agree with you. I mean, we are ready to extend life and take a lot. And people have forgotten, but in the early 90s, there was a fantastic publication in the British Medical Journal where patients were asked how much they were ready to take intense chemotherapy for a level of benefit. And when I was a fellow at that time, I was really shocked to see that for a 1% survival benefit, 54% of patients were ready to take intense chemotherapy, which really tells you that we as doctors think that healthy persons, correct? Mm-hmm. But when you are told you have lung cancer with meds, your way of thinking is completely different. So you really want to survive more. I think trying to unlock the failed indications of immune checkpoints, or the 75% of patients who don't get a benefit from Nivo or from Pembro in the second line is an important endeavor, and we are learning as we go. And I think, these combinations are going to have more toxicities, pretty obvious. I was really taken by the data presented at the plenary in melanoma, although we are discussing long, I think it's important to make comparative analysis. And it's true, I mean, they were hitting 80% survival at 2 years in melanoma, but at the cost of 54% grade 3-4. Well, this is something we're going to need to balance, and we are learning, and hopefully we will also learn to better handle these toxicities, because we understand pathophysiologically that it is the immune system that is attacking parts of the body that are not the tumor cells, and we might be able to fine-tune and decrease to some degree those toxicities. I don't know, Lina, what you have.
I mean, I completely agree. I think there will be a lot of fine-tuning involved, because we are seeing some hints of differences in toxicities that is context dependent. So the melanoma data for combination therapy is very toxic. The lung cancer data is still emerging, but it actually does not appear to be necessarily as toxic. And there might be drug-dependent differences there as well. The Nivo-Ipi combination, although there were some different doses, seems maybe different in terms of toxicity than the Pembro-Ipi combination or the Medi-Tremi combination, the AstraZeneca drugs. So there may be subtle differences that we do need to fine-tune. Certainly if there really is kind of this tantalizing, much better activity with the combination that may not be PD-L1 dependent and may be applicable more broadly, that's important to figure out as well.
Right. That was, with regard to the melanoma data in the plenary session, one of the concepts was that nivolumab, for instance, or Opdivo might work very well in the right population who are PD-L1 expressors and poised to have a good immune response, but those who don't have their immune system mobilized might have it mobilized by treatment with a two-drug combination that includes a CTLA-4 inhibitor, in this case Yervoy or ipilimumab. So I've heard you speak before about the potential for combinations, and do you think that's a potentially very viable way that things to move forward in the next few years?
I do, for select populations. So if we do get to a place where we have more minimal toxicities, and I think there are ways to do that, then I think for select populations like PD-L1 negative patients, that may be a viable alternative. But I think that's where that biomarker becomes even more important, to actually select whether you're going to bear the financial burden of two potentially toxic drugs versus one. And it may be that if you can select out the high PD-L1 expressors, they will never need that combination, versus people who don't have PD-L1 expression at all. Maybe they will get benefit, and overall better benefit than chemotherapy.
If I may, Jack, I want to echo what you say. You know, when we do compare nivo to docetaxel, even in the PD-1 negative, nivo is better tolerated than docetaxel. But when we are talking about a combination, we really eventually need a biomarker to exclude those who will not benefit, because in that case, tox is worse than the one we have from chemo, and that's something we need to keep in mind.
That's a fair point, although I don't know what exactly that biomarker will be for the combination.
I don't know neither.